Finals SAQ51 Tab Block. A. Describe the innervation of the anterior abdominal wall. The anterior rami of T7 to T12 and L1 lie between the internal oblique and transversus abdominis and supply the anterior abdominal wall. Cutaneous branches of these then pierce the rectus sheath to supply the overlying skin. T7 to T9 supplies the area superior to the umbilicus. T10 supplies the peri-umbilical area. T11 to T12 with iliohypogastric and ilioinguinal nerves supply the area inferior to the umbilicus. Iliohypogastric nerve L1 origin and supplies the inguinal region. Ilioinguinal nerve L1 origin and supplies the inguinal hernia sac as well as scrotum and labia and medial aspect of the thigh. This diagram shows the cutaneous dermatomes. B. In which type of surgery would tab block be used and what are the potential benefits? Tab block provides pain relief to the anterior abdominal wall from T7 to L1 level. It is not effective for visceral pain. Spread above the umbilical level is unreliable. Hence, it is useful for any surgery involving the anterior abdominal wall where the incision is below the level of umbilicus, such as abdominal hysterectomy, caesarean section, retropubic prostatectomy, inguinal hernia repair, however will not cover areas supplied by ilioinguinal and iliohypogastric nerves, appendicectomy, lower abdominal open colorectal surgery, and laparoscopic surgery. Potential benefits includes part of a multi-modal analgesia approach, reduced dependence on other modes of analgesia and their associated adverse effects, reduced opioid requirements, which is useful in patients whom opioids may be undesirable, such as those with respiratory disease. Tab block may avoid the need for neuraxial technique in patients in whom this is contraindicated, such as patients with coagulopathy, however unlikely to be as effective as a neuraxial technique. Tab block offers pain relief after emergency caesarean section, where urgency does not permit neuraxial technique. C. Outline how would you perform a tab block. Ultrasound-guided approach. Preparation, including consent, assess for contraindications, presence of skilled assistant, resuscitation drugs, venous access, assembly of equipment, aseptic technique, full monitoring should be available. Ultrasound machine with high-frequency linear array probe, sterile cover, 0.5% chlorhexidine spray, sterile ultrasound gel, 50 to 100 mm block needle, 20 to 40 ml of local anesthetic, and 10 ml of saline. Clean the patient's skin and allow air dry. Patient in supine position. Ultrasound probe transfers to the orientation of the patient in mid-axillary line between the ribs and iliac crest. In-plane introduction of needle to reach the space between the internal oblique and transversus abdominis. Inject saline to confirm that needle is in the correct plane. Then inject LA in 5 ml aliquots. Volume of 20 to 30 ml in total per site, aspirating prior to each injection, watching transversus abdominis plane expand with injection. Bilateral blocks are required for midline incisions and incisions that cross the midline. For the landmark technique, preparation is as for ultrasound-guided technique. Triangle of Petit should be identified by palpation of iliac crest inferiorly, anterior border of latissimus dorsi posteriorly, and posterior border of external oblique anteriorly. 50 mm block needle is usually sufficient, as a more direct approach to the plane is taken. Needle is inserted perpendicularly to the skin in the triangle of Petit just above the iliac crest in the posterior axillary line. 2 pops are felt as the needle passes through the fascial extensions of the external and internal oblique. Aspiration should be negative prior to injection. Volume of LA 20 to 30 ml per site. D. What are the specific complications of a tab block? This includes failure. There is significant variation in degree of LA spread with tab block. Local anesthetic toxicity, especially when large volumes of LA are used in bilateral block. Incorrect site of injection. However, use of ultrasound reduces this risk. Incorrect sites of injection includes intraperitoneal injection, intrahepatic injection, bowel perforation or hematoma. transient femoral nerve block may occur. Additional information. Chairman's report, 67.4% pass rate. Question was relevant and topical. Many candidates had poor knowledge of innervation of anterior abdominal wall. Types of TAP blocks. These include subcostal, lateral, posterior, and oblique subcostal. This is described in detail by SAQ51 et al. In 2017. For the subcostal approach, main segmental thoracolumbar nerves to be blocked includes T6 to T9, which supplies the upper abdomen just below the xiphoid and parallel to the costal margin. For the lateral approach, this aims to block T10 to T12, anterior cutaneous branches, which supplies the anterior abdominal wall at the infraumbilical area from midline to mid-clavicular line. Posterior approach aims to block T9 to T12, anterior cutaneous branches, and possibly lateral cutaneous branches, which supplies the anterior abdominal wall in the infraumbilical area, and possibly lateral abdominal wall between the costal margin and iliac crest. Oblique subcostal approach aims to block T6 to L1 anterior cutaneous branches, which supplies upper and lower abdomen. Lateral approach is the most common approach. The probe is placed over the mid-axillary line. At this point, the three abdominal muscle layers are evident. Needle can be introduced under direct vision. Limitation of this approach is extent of analgesia achieved, with the block being limited to infraumbilical region. Another approach is the subcostal approach, where the probe is orientated subcostally along the inferior aspect of the rib cage. Identify the three abdominal muscle layers. Needle is inserted in an in-plane manner under direct vision until needle tip is seen within the TAP. Care to avoid neurovascular trauma. Needle is generally orientated at right angles to the vessels in the plane. This block is usually used for supraumbilical surgery. Catheter may be placed with this approach as the effect is localized to within the TAP. Posterior approach. The probe is placed posterior to the mid-axillary line. Identify posterior aspect of abdominal wall muscles and the quadratus lumborum muscle further posteriorly and medially. Needle is advanced in plane under direct vision to lie superficial to the transversalis fascia at the lateral border of the quadratus lumborum muscle. Prior to administrating LA, care is taken to ensure needle tip is extravascular. With this approach, LA solution has been shown to spread locally within the TAP and also superior-medially to the thoracic paravertebral space. This paravertebral extension mimics spread pattern associated with landmark-based approach. This helps to explain effective field and duration of analgesia through probable involvement of thoracic lumbar sympathetic ganglia. The oblique subcostal approach is a modified subcostal TAP block which was first described by Hebat et al. By hydrodissecting the TAP along the oblique subcostal line from xiphoid toward the anterior part of the iliac crest, the anesthetic solution spreads across the location of T6 to L1 nerves and thus potentially covers both upper and lower abdominal walls. The dual TAP block combines subcostal with lateral or posterior TAP block. This provides a wider coverage for both upper and lower abdominal walls. These are my references. Thank you.